And what's in
Feel
the
free to make us co-host.
Oh, yes. Okay, well, welcome back. Good morning, good afternoon, good evening to everyone. I hope everyone's doing well. It's another Tuesday VMR with myself, Mengyu, and Alec. Excited today. And today we have Kushal, who's going to be presenting us a case. Kushal, if you're able to, can you unmute yourself and just introduce yourself to everyone who doesn't know you?
Hey, hi everyone. So I'm Kushal, and my favorite flavor of ice cream is mint chocolate chip with extra hot chocolate and with extra roasted nuts.
I love how prepared you were, and what a great answer. So that's a great start to the case here. I'm just going to make a Mengyu a
I don't think I've
co-host.
ever put
And
roasted nuts on mint chocolate chip. I will have to try that. What type of nuts?
Just different flavors, probably almond and pecans.
Got to do it.
solid. Well, I guess if we can pull up the whiteboard, we can go ahead and get started.
So the case is going to be called as If You Seek It, You Will Find It. And the first aliquot is a 20-year-old male presented to the ER with wheezing and dyspnea. Do you want me to go ahead and give you the HOPI or stop here for discussion?
Is this where you had planned to stop, or did?
Oh, yes.
Okay, yeah, no, then we can stop here. I think that sounds great. So I guess, Alec, you want to get us started, or do you want me to take the first stab at it?
I think I went first last time, and so I think maybe you go first, and then maybe I can go second, and then you want to do third this time.
Okay, no, that sounds fine. So yeah, we have a young person here presenting with wheezing dyspnea. I love the title of the case, but I don't want to read into that too much to bias my clinical reasoning. So when we have a young person presenting to care,
Sure.
we always have to think about, what might have them seek care, because many young patients go many years without seeking care, and so usually that suggests that there is a severity to their illness that should sort of make our antennas go up, but that's not always the case, but should always be in the back of our mind. When I see the combination of wheezing and dyspnea together, I mean, I think that puts us from a type 1 thinking standpoint into the lungs. In particular, there are certain diagnoses to think about, but we don't want to anchor on that at this point in time. So I think with all that in mind, really, I'm going to try to get a sense of, what is the severity of the presentation that the patient is coming in with? Are they coming to the primary care clinic? Or are they presenting to the emergency room? What are their vital signs? And then start building around that. But don't want to dive in too much right now. So Alec, or I guess Mengyu, what do you think?
Yeah, I missed the first part, but I think I see a young patient with wheezing and dyspnea. I think the reflex thinking is asthma, and but if the patient has never had history of asthma, that I think would definitely just still keep my differential very open. And depending on the location of the wheezing, there could be unilateral wheezing, which you can think of some obstructive disease, and then bilateral wheezing, then it's different. So and anything along the line of asthma, like secondary causes, like I think are all under differential, which I'll not go into detail for now. Just wait to hear more history.
Excellent. Yeah, I don't think I have too much to add on that. And I think, like last week, not last week, the last time that we discussed, we had a young patient and we always talked about, um, you know, bad genes, bad luck, or bad behavior. And I think that's something that maybe we'll have to apply to this depending on the background of the patient and if they have a history of, primary lung disease. But I agree with Austin that the center of gravity seems to probably be the respiratory tract, or sorry, I should say the pulmonary system. Um, and the base rate of dyspnea is centered in the cardiopulmonary system. So I think we'll just have to get more information about the background and the foreground to really dive into what is the problem we'll be solving. So I'd love to hear more, Kushal.
Okay. So the history of presenting complaints, 2 months ago, he was normal. And within the 1 to 2 months, he developed low-grade fever, cough, which was especially present at nighttime, mild sputum expectoration, not blood-stained, lost about 2 to 3 pounds weight, Wheezing was there, which is increasing frequency. He's a known case of asthma patient, but he had it once in 8 months. But in the past 1 to 2 months, his frequency increased by almost every week. He had one episode. So he did visit his primary care physician for that, and they treated him for respiratory tract infection and did talk to him about having to consider a step-up treatment for asthma if it persisted after the antibiotic course was over. Today, he was brought with the wheezing while he was playing cricket with his friends, and it didn't subside with his taking his inhale or puff. And the past history is known case of asthmatic on albuterol and had primary complex TB 10 years ago and completed his course of AKT4. And social history is from southern India, part of fisherman community, not a smoker, not an alcoholic. Family history is a diabetic. Do let me know if you want me to repeat anything.
Okay, wow, yeah, thanks for that, and certainly have a rich background here to go off. I think I'll try to focus on the HPI and then leave the past history for Alec and Mengyu, and then they can chime in on the HPI as well. But again, sort of as Alec has mentioned, we had sort of confirmed that this patient has asthma. I think whenever you see a diagnosis of asthma, see a diagnosis of COPD, see any diagnosis for that matter, we should always step back and ask ourselves, like, how was this diagnosis made? In a young person presenting with wheezing before, the base rate would say this is probably asthma, but certainly seen many patients in my clinic, because I'm primarily a primary care doctor, that have a diagnosis of asthma, have a diagnosis of COPD, but don't have the appropriate testing to corroborate that diagnosis. And so can lead to a lot of mismanagement and a lot of issues with care. And as we always talk about here, if you don't have the right problem, you can't solve it. And if you don't have the right problem and you're treating the wrong problem, then you're never going to fix that problem. So, making sure we have diagnostic clarity about what if their asthma is truly asthma will be helpful. That being said, we have a story that seems to be consistent with asthma, and it seems like their disease is worsening. So now we have to ask ourselves, if we're making the assumption that this patient does have asthma, why is it getting worse? So I think most commonly is sometimes, asthma is a disease. It's a spectrum of disease. So it's possible that just as the patient is getting older, things have changed in their life, and the disease is worsening. But I think the most, we think through the sort of triggers of asthma, we think about classically like exertion. So this patient was playing cricket and had worsening symptoms, but it doesn't seem like the issues with the progression or the recurrent episodes that the patient is having is isolated to episodes of exertion. So that's probably not what's at play here. Then we think about environmental exposures, so like pollutants or allergens, or maybe the patient changed where they lived, and there's mold exposure now, and so they're having worsening symptoms there. Then you think about their medication, so maybe their patient was on a prescribed medication and they're having trouble using it, or the most common reason why patients have worsening pulmonary disease, whether asthma or COPD, is because of that we don't do a good job teaching them how to use their inhalers properly. So this patient's only prescribed albuterol. It sounds like there was a discussion of doing step-up therapy. So if that happened, then just making sure that the patient is using their medication appropriately is something that often will be diagnostically fruitful. I think the last thing we have to think about is, maybe this person doesn't have asthma, as we were talking about before, and this is a sign that their whatever underlying disease was present before is progressing. And so whenever you have a syndrome of what looks like allergies, there's a few, or asthma or atypy, there's a few diagnoses that come to mind. So one being like vasculitis, like EGPA in particular. Another one being centered in the lungs in the form of infection, which is like allergic bronchopulmonary aspergillosis, which classically presents with patients presenting with recurrent what looks like asthma exacerbations. But it's too early to anchor on any of those particular things. But we have a patient with now sort of like a chronic syndrome of sort of worsening or progressively more frequent exacerbations, with an inflammatory signature, which asthma isn't necessarily inflammatory unless the patient is having recurrent infections and has a form of immunosuppression. But I think I've rambled on enough, but there's so much more to figure out here. And so Mengyu and Alec, what else do you have for the HPI, and then what about their background?
Yeah, Alec, have we decided who goes first after Austin?
Go ahead, Mengyu. Go for it.
Sure. Yeah. Yeah, I think that's such a rich aliquot, Kuchel. Thanks for this case. I think the past medical history, one is beyond the history of asthma, we also have a history of TB. So I was trying to think how that would change our add to our differential. What I think of TB is it could lead to underlying structural disease, so making patients more prone to certain infections, which includes certain fungal infections like endemic fungal or aspergillus, and could form aspergilloma. Although when we think of aspergillosis and asthma, we think more of the ABPA type of picture. And then as the fact that patient is from Southern India in a fisherman community, I'm trying to reflect what that would add to our differential. I think one is there might be exposure again to fungal and to certain NTM like mycoplasma marine type, marinum type, I think, which our ID Quinn mentioned in the chat as well. And then another thoughts along the line of history of TB, which I forgot to mention, is whether it will leave some local disease, may be related to TB or maybe just separate, like a local lesion, especially if it causes more localized wheezing. But I think the exam will inform us on that. So those are my thoughts right now. How about you, Alec?
Awesome. Yeah, I love that, Austin. And then you just setting up, potential diagnoses, but additional ways to layer in the background that the patient and Kushal has given us. And so I agree. We just need to figure out the driver of this progression and really define, is this acute intermittent, or is this acute episodes on a subacute worsening? Seems like the patient was fine, and I would be interested to know what age the patient received the diagnosis of asthma. And then I think Kushal mentioned that he was having exacerbations maybe like every 8 months or so, so very, very infrequent. But getting a sense, was the patient diagnosed at 12? Was he diagnosed at 24? I think that may speak to the actual chronicity of this, or if this is something truly acute that happened over the last few months or longer. And then I think getting a sense of any additional associated symptoms that might give a signal for some of those other things. You had mentioned EGPA, what could they have joint pains or other things as well. And then, yeah, the fisherman community is certainly interesting. I don't really know much about Southern India and the certain infectious diseases that may live there, but we'll just have to layer that in and also get a sense of, what the patient does for a living and any additional new changes in his life that potentially could be leading to this. And then I agree with Mengyu's sentiment about whether the TB could have caused some underlying structural lung disease that predisposed him to something else. And I think it seems a little odd that he had TB very, very young, 10 years ago, and then all of a sudden now something is happening, but something to keep in mind. And, I think as well, whenever I hear wheezing, I always wonder where that wheezing is coming from. I think many times, you'll hear, you get signed on a patient say, oh, the patient is wheezing, and you go to listen to the lungs, and the lungs themselves actually sound okay, and they're actually wheezing up here in their neck. So you always have to think about upper airway, obstruction or intermittent obstruction as well, and whether the positional changes to the wheezing, whether it's worse when he's laying down or sitting up. But it seems to be more related to exertion and other history consistent with progression of his underlying asthma. And what is triggering that, I guess, will be the problem that we'll be trying to solve, at least at this point. So looking forward to hearing more.
Yeah. So just wanted to let you know, he's having asthma since he was 10 years old. And the next solid plot is the physical exam. His temperature was 100. His pulse rate was 110. BP was 99/70, and respiratory rate was 30. SpO2 and room air was 96%. He was moderately burped, gasping for breath. Accessory muscles were prominent, not ectric, not anemic, no cyanosis, no clubbing, no edema. But axillary and inguinal lymph nodes were palpable, just palpable. And CVS, he was tachycardic, no murmur, respiratory rate, reduced chest expansion, and bilateral crepitus in lower zones with occasional rhonchi. Abdomen was normal. Would you like me to give you the first set of labs, or would you like to discuss this one?
Wherever you'd like to stop, Kushal.
Okay. Yeah, it's starting.
Oh, wow. All right. Wow. Yeah. Visual. And just to clarify, Kushal, did you say crepitus on the patient's exam?
Yes, he had bilateral crepitus in the lower zones.
Okay. And then you said rhonchi, but no crackles or
Occasional
wheezes.
bronchi.
Okay. All right. Well, thank you very much for clarifying that. Okay. Wow. So if we take a step back and we look at the patient, I am terrified. I mean, the patient is very, very sick. I mean, they are have accessory muscle use. They're tachycardic. Their blood pressure 99/70 for a 28-year-old man. Could be normal, but probably represents a low blood pressure in this particular scenario. So this patient is very, very sick, and so we're going to be prioritizing management over diagnosis, at least when we first evaluate the patient here. But if we try to make progress with the physical exam here, I think what we've confirmed is that there is something going on within the lungs. We already had suspicion for that, but now I have physical exam evidence to corroborate that. But I think the second thing that we have here is this lymphadenopathy in the axilla, in the inguinal regions, which again, I think we had signal potentially that there was a inflammatory systemic syndrome going on, but now we have even more evidence of that. So I think if you take the working hypothesis of asthma and layer in lymphadenopathy, are those two things compatible with one another? And I would say there are certainly ways to put them together, right? Let's say the patient has asthma, they have pre-existing, chronic or structural lung diseases, as we already outlined in the last aliquot. They develop an infection. The infection became systemic, so something potentially more indolent, like a fungal infection or mycobacterial infection, for example. And that's leading now to this lymphadenopathy. That's certainly possible, but I think given the time course of it seems like we've been having these worsening asthma type symptoms plus lymphadenopathy, I think this puts us more into a different systemic disease category. But I think it's going to be difficult to make progress on that, at least with just the information we have right now. So which systemic diseases could we be thinking about in particular? Ooh, so this is I think this is where I'm going to be stretching my illness scripts a little bit. So I'm going to be excited to learn more. But of the diagnosis we were entertaining before, so vasculitis, certainly consideration, absolutely. What about the ABPA? Not something that I typically think of causing lymphadenopathy, but I just don't know enough about that to be sure. Other like infectious things like strongyloides, something like that. I don't typically think of that without other certain features that causing lymphadenopathy. So I'm going to be interested to learn more. And then obviously we have this crepitus on the exam too, but I'll leave that to Mengyu and Alec to discuss here.
Yeah, awesome analysis, Austin. I don't know I have too much to add. I think one thing I was reflecting is that we don't hear like the classic bilateral, diffuse wheezing that we see in asthma exacerbation, but instead we hear the description of lower zones crepitus, which I think on one hand we kind of have to make sure it's not a heart failure, because sometimes that sounds like a wheezing and then presenting as dyspnea. And so I think some labs and imaging would easily help us rule that possibility out. So far, I haven't heard any other signs of systemic peripheral overload, like a lipedema or GVP, but we'll see. And then the other thing is, again, I agree with your analysis about lymphadenopathy, which suggests to me like a systemic inflammation, including an infection like granulomatous infections. But yeah, I'll pause here and hear what Alec has to say.
No, thanks, Mengyu and Austin. I don't think I really have all that much to add. I think just with the lymphadenopathy alone, we know this is asthma plus something else. This isn't just the patient's asthma is getting worse because it's getting worse. There's something else that's going on here. And we'll have to decide whether it's this whatever's causing lymphadenopathy is worsening his underlying asthma, or if there's actually a pulmonary disease driving the worsening of the asthma in addition to this lymphadenopathy that we'll have to link together. And the crepitus in the lower zones of the lung, certainly, again, I agree, just screams the lung. We'll have to get advanced imaging of the lungs to really get a sense of what's going on there. And the reduced chest expansion, could speak to the underlying obstructive disease. And just I guess a reminder is if patients aren't moving air well enough, you may not hear wheezing. And the patient is not significantly hypoxic, although 96% for a young man may be lower than you would expect, but he is tachypnic, and he is tachycardic, and his temperature is a little bit on the higher side. So certainly we have systemic syndrome with sort of a pulmonary and reticuloendothelial predilection that we're going to have to try and solve a little bit more, because it seems like the patient's asthma otherwise was pretty well controlled. So I'm very interested to learn more. And as far as what labs I'm going to really sort of center myself in, I'm definitely going to be fascinated to see the CBC, to see what the differential is like, particularly looking for eosinophilia or anything else that could be funky, whether there could be evidence of autoimmune flavor that we might see in the WBCs or the platelets. And then, looking as well for sort of other signs, and then definitely advanced pulmonary imaging, chest X-ray for sure, but certainly in this patient, I would already be thinking about a CT scan likely, just to get a better characterization of what is going on. And yeah, I mean, I think it's hard to make too much progress, hard for me to really sort of speak about specific diagnoses because I want to be sure I'm solving the right problem. So I'm really looking forward to hearing more. Awesome case so far, Kushal.
Yeah, I think the chat is on fire and many people are on the right track. Hemoglobin is 13 and total count is 30,000. DC was neutrophil was 38, lymphocyte was 25, monocytes 2, eosinophil 35, absolute eosinophil count was 5,000. Platelet count was 150,000. Serum electrolytes was within normal limits, and LFT was normal. RBS was 95. Urea was normal. Creatinine normal. ESR was 60, and CRP was increased, which is mild. ECG was normal. Chest X-ray showed a reticulonodular pattern, predominantly in the lower zone.
Okay, wow. Is this the how many more aliquots do you have left, Kuchal?
I have 2 more aliquots, though.
2 more aliquots. All right, so I don't have to. I don't have to commit quite yet. All right, very good. Okay, so yeah, so now I think we have a bit of a turning point here, and it's the CBC. So if I heard you correctly, the patient has an absolute eosinophil count of 5,000.
Yes.
Okay, with a white blood cell count of 30. And then some, otherwise, most of the labs, besides some inflammatory markers, were pretty much normal. Okay, wow. So, I think this again speaks to the possibility this patient has this patient has a systemic disease, and it seems to be eosinophilia predominant. So now we're going to be solving the problem of eosinophilia, in particular hyper-eosinophilia, given the degree of the absolute eosinophil count being elevated, and then layering in the patient's features of their presentation that we already have seen into those potential diagnoses. So when I think of profound eosinophilia or hyper-eosinophilic syndrome, sorry, that's hard to say fast. I think you could break it down into primary or secondary. My illness group for primary disease is not very robust, but it seems, at least in my experience, this patient is quite young to be having a primary sort of blood disorder or cancer to cause a hyper-eosinophilic syndrome. So I think that's a little bit lower for me, but that's potentially a knowledge gap. So I could definitely be wrong about that. So if we go into secondary causes, I think we could think about drugs, which we don't really have the history for, at least right now. We could think about exposures. So in particular, like infection exposures. So the ones we think about, certainly fungal infections can do it. And then the parasitic infections, the other thing we'll be worrying about. And then the last would be sort of like a primary, like autoimmune disease, for example, which we've discussed a few. So now how do I layer those things in with the lymphadenopathy? Again, I'm a little bit uncertain, but I guess, when you have this much eosinophilia, it can sort of invade and infiltrate, many, many tissue types, regardless of the potential etiology. So, if I make a leap on the illness script I have, I think that, could definitely be explainable. But as far as how to make progress from here, I think I would be going back, scrutinizing the patient's exposure history. I just don't know enough about that area of injury and what the patient does with fishing that could lead them to certain exposures. So I'd be exploring that and looking more into that. Definitely consulting infectious disease, sending some infectious disease tests for sure. And then sending ANCAs most likely, as well as, you know, the more common types of infections that can cause eosinophilia that we've outlined before. That'd probably be my approach. And then, you know, clarifying the imaging a little bit more, as Alec already mentioned. So, wow, definitely stretching me on this case. So I'm really excited to learn more. But Mengyu, what do you think?
Yeah, what an interesting case. I really agree with you, Austin, you know, in terms of the approach with primary and secondary. And I usually, when I hear eosinophil, depending on the severity, so 500 to 1,000 is like mild, and then 1,000 to 1,500 is moderate, and above 1,500 is severe. So this patient has a pretty severe eosinophilia, and definitely then some of the differentials like on our eosinophilia framework would be less likely, like you know, as a like adrenal insufficiency or things like that. But I agree with the differential that Austin brought up, which includes, I think for primary, I think about hypereosinophilic syndrome. And when I think of that, I kind of have to think about the end organ that it affects and assess, maybe going back to the patient's bedside to see if there's any involvement of those organs, which includes skin, look for any rash, lung, as the patient already has, and then GI tract and the heart. So I think someone mentioned echo is a good point. And the eosinophilic leukemia, I think, is also possible. So I think for that, maybe a blood smear or even a flow cytometry would be helpful. And the infection, I think, is also broad, and depending on the patient's exposure, I think that's an area I would definitely love to learn more. I think things like spongy are definitely possible, and fungal can also cause eosinophilia, but so I think those are definitely all possible concept idea, as Austin mentioned. And I think if it's primary eosinophilia, I think there are certain workups like vitamin B12, tryptophan to help illuminate those. But yeah, how about you, Alec? And by the way, I'll just add that I think imaging will be helpful to see the pattern of the lung involvement. Is there anything more local, or is it like a more non-specific infiltrates? But yeah, Alec, I want to hear your thoughts as well.
No, amazing. So I definitely think this is at least our first pivot point of the case with this hypereosinophilia. And I agree with everything you said. And I think I would just expand, you know, as far as the other malignancies, in addition to eosinophilic leukemia, would be lymphoma. I think Hodgkin's can cause a significant eosinophilia as well. And then to be more specific about some of the autoimmune conditions, it's not that common. You can't see it in sarcoid. I think you can see it in lupus. So there's probably some others that I'm mentioning as well. And then just thinking about other things like acute eosinophilic pneumonia, or more likely in this case, chronic eosinophilic pneumonia as well. And then agree without the clear cardiac or other manifestations that hypereosinophilic syndrome. Otherwise, it's a tough diagnosis to make, and you have to exclude everything else. So I think definitely I'd be talking to IED, looking more about India, and then specifically the parasites that might be there and the best way to go about testing for those. And then, you know, I totally agree as well. We need more advanced lung imaging to really characterize what is going on intraparenchymally. And I think that can really be tremendous in narrowing our differential diagnosis. And then getting a true sense of the extent of this lymphadenopathy as well. Is it just localized to the axilla and the inguinal region? Seems very unlikely, but, you know, do they have hilar lymphadenopathy? Do they have lymphadenopathy in the neck? What's the size of the lymph nodes? How should we go about managing this as well? And then, you know, whether or not we will actually need to pursue a lymph node biopsy for one of these to exclude some of the other diagnoses in the future. And then agree with Mengyu with the tryptase and the flow cytometry and the smear, and then, you know, ruling out systemic mastocytosis with the tryptases, something you could do as well as a part of the algorithm. But very fascinating. You know, I guess I wonder if I wanted to challenge myself with the patient's age and the sort of progression of the syndrome thus far, is would we prioritize one category over another? And, you know, I think with the age, infection probably will be there. The lack of clear other symptoms otherwise makes me think autoimmune disease a little bit less likely, but I think the imaging can give us additional characterization there, or whether we go back on physical exam and pick up other things that we were missing before, joint pains, rash, synovitis, ulcers, whatever. And then, yeah, using the power of the imaging and the progression of the patient's clinical syndrome with, time again being the best diagnostic test. And yeah, I would also be interested to know as well when the patient was treated for this, exacerbation with antibiotics, if the patient also received steroids as an outpatient as a potential part of an asthma exacerbation, and whether or not they felt better, because sometimes that could be potentially useful as well as far as determining what is going on. Sometimes not, but sometimes yes. So very interested to learn more.
I think you're muted, Kuchal.
Can you hear me now? Yeah, so the next I'll report, the peripheral smear showed leukocytosis with marked eosinophilia, no left shift. Echo was normal. HRCT showed central nodules in the mid and lower zone, along with a smooth interlobular septal thickening. Pulmonary function test showed concomitant obstructive and restrictive pattern. Sputum was insufficient, so we went ahead and did valve. And eosinophilia was positive. It was negative for TB. Serum IgE was elevated. ANA was negative. P-ANCA, C-ANCA negative. Serum C3, C4 were within normal. Serum Aspergillus fumigatus, specific IgE and IgG were negative. Serum anti-strongyloids antibodies were negative. So the next report will reveal the diagnosis, just the last set of investigation and diagnosis.
All right, wow. And then did we have a urinalysis somewhere? I may have missed it.
UA was normal.
UA was normal. Okay, thank you so much. So, and then to clarify the high-res CT scan, so the patient had predominantly in the mid and lower lung fields had centrolobular nodules, is that right?
Yes.
Okay, all right. And then with some intralobular septal thickening as well.
Yes.
Okay. Wow. Okay. So I'll say straight up, I have no idea what the diagnosis is here. So I'm just very excited to discuss this case so I can learn more. But now, to layer in, we have a young person presenting with in respiratory distress found to have systemic inflammation, likely diffuse lymphadenopathy, CT with of the lungs with centralobular nodules in the lower and mid lung fields, and then hypereosinophilia with the absolute eosinophil count of 5,000 and elevated IgE. So that's my off the cuff proper representation, which wasn't particularly good. But if I try to layer in IgE plus hypereosinophilic syndrome plus lungs with pretty much a negative autoimmune evaluation to date, though the ANCAs can sometimes be negative, so you have to take that with a grain of salt. I think we're centered on potentially in infectious etiology here. The centrolobular nodules, CP solvers have a really nice schema as far as approaching nodules on the CT scan and how to clarify, what potentially the primary etiology is. I don't have the ability to pull that up right now, so I'm going to try to remember it off the top of my head. And so please go back and make sure that I did it correctly later on if you're watching this video, so you don't learn incorrectly. But whenever I think about centrolobular, basically you can think about the airway, enters pretty much directly into the middle of the secondary pulmonary lobule. So whenever you think of the airway, then basically this means that the patient probably breathed in something, and this is the cause of their symptoms potentially. So what can you breathe in? So certainly toxins or inhalants, certainly you can do that, but we don't really have that exposure history. Basically in infections, so in the form of different types, so that would be viral, which we don't really have the case for here, bacterial, which would be very, very uncommon in the patient presentation. So basically we're into the atypical infections, in particular fungal infections. So that's where I would be thinking right now how to layer in the elevated IgE. I typically associate IgE with aspergillus. We have an IgE specific antibody for aspergillus, which was negative. I don't know the performance characteristics of that, so that would be interesting to know. If I remember correctly, it's pretty good. So I think it doesn't necessarily exclude other types of aspergillus or other potential fungal infections, but I would be interested to sort of explore those test characteristics a bit more. So how would I go on from moving here? So I'm curious to see how we're going to arrive at the final diagnosis. I think probably it's going to be an infectious disease test of some kind. And I think we're sort of centered on the lungs, and that's where I'd probably favor doing the evaluation, but we certainly have the lymph nodes in the background, which are probably reactive though. So wow, really getting stretched, excited to learn more and hear the final diagnosis, but let's see what Mengyu and Alec have to say.
Yeah, Austin, that's a great analysis. I really don't have too much to add. I agree with you in terms of when it's central lobular multiple lung nodules, I would think of airway predominant, and from there I would mostly concerned about infection as the etiology. And here is an area where I would really like to learn more about what are the potential infections that would cause this high of eosinophilia. But I think fungal and parasites are the two big categories. And I would imagine the next step would involve a bronchoscopy with lavage and potentially a biopsy. And I was trying to read about the elevated IgE. I think besides from allergic reaction, I'm still trying to find the answer, but I wonder if there's anything like a hyper IgE syndrome or something with a stata 3 deficiency. I don't know. This is like a weird area where I'm not that familiar with, and would curious to learn more about that, because that could also be associated with certain infection. I think I'll pause here and see if Alex has any thoughts.
No, I don't have too much to add, and I definitely need to do some reading on everything, but particularly the IgE. I think in my experience, the elevated IgE just can typically be seen in patients that have eosinophilia, and I'm not sure that it adds a lot as far as specificity, but I could be very wrong with that. So I look forward to looking that up. And I think again, just building off on what you both have discussed, I think the fact that this is a young patient has a predominant eosinophilic signature, and I think it would be interesting to go back as well as the patient has developed the syndrome, is back when the asthma was better controlled. What was the eosinophilia like? Had the patient ever had eosinophilia before? And I think that spectrum may speak to the acuity. And I think I would like to know, again, the sort of infectious disease of the community, because I still feel like I agree with you both that it's more likely to be an infectious disease at this point. The lymphadenopathy, though, is very curious. And it seems like the bronchoscopy was otherwise pretty unrevealing besides the eosinophilia. So I'd be interested to know every test that was sent there and what exactly was worked up. So as far as what I would do next, either there's going to be a specific serologic test. We're going to evaluate for the parasites in particular, or the other endemic mycoses with either serologic or I guess stool testing potentially for parasites, or whether or not it might just be easiest to go for the lymph node, just to get a sense of, is it just truly just secondary inflammation, or is that going to harbor some of the primary driver of this as well? And I'd probably be doing all concurrently and discussing with my colleagues and specialists about what would be the best way to obtain the diagnosis here. But this is going to be something I probably don't know anything about, or if it is something that I've heard before, it'll at least expand my illness script. But I think as well that the fact that it's not really in the upper lobes makes the chronic eosinophilic pneumonia a little bit less likely also. So yeah, Kushal, tell us what happened to this patient? How are they doing?
Okay, so then we did try rolling out non-infectious causes for eosinophilia, which he had, and its history course is chronic more than acute. So we tried rolling out the chronic eosinophilic pneumonia is not there, especially because the patient had Bs and he didn't really present with a dyspnea, and the chest X-ray was showing a reticulonodular pattern. And usually with chronic eosinophilic pneumonia, they would have infiltrates in the alveoli. So we ruled that out. And we were thinking of also GPA, but the ANA, everything was negative. And then since he had asthma, we were considering probably he has aspergillosis, and that was negative. And he was not immunocompromised in terms of even if it was HIV negative. So the last test which we did do was the antifilarial antibodies, and that came out positive. So we diagnosed him to have the tropical pulmonary eosinophilia, and we treated him with DEC, diethylcarbamazepine, 6 milligrams per kg for 21 days. And he is symptom-wise, he improved drastically with just like a couple of doses. And after the 3 weeks dosage, we repeated the chest X-ray, and it's symptomatically there was an improvement. And we also repeated the PFT, and he was almost back to normal, just like mild obstructive pattern was there, but we thought probably it's because of his history of asthma. So we diagnosed him to have a tropical pulmonary eosinophilia.
Wow. I've never heard of this diagnosis. I had no idea what this is. Wow, that was incredible. Thank you so much for bringing this case. I'm really glad to hear that the patient did well. Sort of reflecting on the case, I think we did it. I think one thing we did particularly well was not trying to anchor ourselves in a particular diagnosis. And I think that proved fruitful here in the sense that, the diagnosis was something I have never heard of. So I think we arrived at something in the infectious category, which was correct. So I think it just goes to show that if you're systematic about how you approach things, even if you don't know what the diagnosis is, even if you sometimes are diagnosing a new disease that's never been discovered. I presented a case to Robbie and Reza of a disease that had never been described before. And you can make progress as long as you're trying to avoid the trap of anchoring on a particular diagnosis. So I think I'll pat myself on the back for that one. But as far as how we can grow from here, I think the one thing that we didn't explicitly state was talking about what the patient's immune status was. I think we alluded to it a little bit, but we never asked for the HIV test, which was foolish in hindsight, because that would have definitely dramatically changed the differential diagnosis potentially, or certainly opened us up to the possibility of malignancies a little bit more. Man, so many reflections, so much to learn. ID is a particularly weak spot for me, so I really appreciate this case, because now I'm going to have to go read even more about infectious disease. So I'm just really, really thankful for you bringing the case. And I guess Mengyu and Alec, what reflections do you have?
Yes. Yeah, thank you so much, Kuchar, for this case. I think I learned this back in as a medical student, but since then I never learned any case, and I don't have any notes about filariasis in my bring back. So definitely eager to learn more about it. And I saw awesome chats that I think brought up this diagnosis earlier. So I was definitely eager to learn more about different. I think one area might be like what kind of parasites tends to involve the lung or travel to the lung as part of their life cycle. And I remember filariasis mostly causing lymphedema from my remote memory, but I'm definitely interested to have more robust illness group as well as differential for parasites infection that involves the lung. And I also love your reflection, Austin, about the immune state and things. Yeah. How about you, Alec?
No, what an amazing case. Thank you again, Kushal, for putting this together. And yeah, I've never heard of this diagnosis before. And I think I'll be curious to read as well beyond serology, whether like you can actually pick this up on bronchoscopy, like you can isolate the filaria or not. I think that'll be interesting. But I agree with Austin's reflection is that HIV should have been on the differential much before, eosinophilia in and of itself, maybe not to this severity, but just defining the patient's immune status was critically important, and that's a good reflection. And yeah, I agree with having a good framework, and I think we were all leaning towards a parasitic infection, but which one we weren't there. But that's why you have colleagues, and that's why there's the internet and books and up to date to help you. So yeah, just an amazing case, lots to learn from, and I really appreciate your time. And I think we can pass it to Omaima to help us with the teaching points.
A wonderful discussion, and thank you so much for the case, Kushal. So for this case, we started with a 28-year-old male who presented with wheezing and dyspnea, and we talked about how young patients seeking care is often a red flag because young people tend to seek care much later, and it's often reflective of the severity of the illness. We also talked about the combination of wheezing and dyspnea and how it's us towards the cardiopulmonary system, especially the lungs. And when we have wheezing, it is very important to also determine its characteristics, like the location, whether it's unilateral, whether it is in the upper airway, whether it happens in the inspiratory or expiratory time, and whether there are any changes with the positional changes. The PMH revealed a history of asthma and TB. We talked about how any history of asthma or COPD should be further investigated, because it's not rare when patients have the wrong diagnosis, and it's important to have diagnostic clarity to make sure that we are treating the right problem. And in a patient with asthma, it's important to make sure that the history is consistent, like the triggers, and to make sure that the patient is very observant of his medications. The patient also had a history of TB, and we talked about how TB can cause structural disease, making patients more prone to infections like aspergillosis or Mycobacterium marinum, given that the patient is also a fisherman, or parasitic etiologies. The physical examination was very worrisome in this patient, and it further reinforced the pulmonary etiology. However, we also found lymphadenopathies, and we talked about how this moves the needle more towards systemic diseases like chronic granulomatous disease or malignancy. The CBC later revealed hypereosinophilia, and we talked about how there are primary and secondary causes of hypereosinophilia, the primary being mostly hematologic malignancies, and we need a peripheral blood smear to diagnose that, or secondary, like due to drugs, exposures, atopy, autoimmune diseases, and how the history needs a very detailed history to look for exposures for any fungal or parasitic infections. And when we have eosinophilia, we need to think about the end organ that is affected, like the skin. Do we have any rash, lungs, do we have any wheezing, or the heart? Later, we found a combination of elevated IgE plus hypereosinophilia and lungs, and this raises concern towards infectious etiologies, especially fungal and parasitic. And we found this intralobular nodules distribution, and we talked about how this often happens in airway predominant diseases and how it can be present in hypersensitivity pneumonitis. We ended up with positive antimalarial antibodies, and patients ended up having tropical pulmonary eosinophilia, which is a diagnosis that is very new to me, and I'm excited to read about it. Thank you, everyone.
Wow, amazing summary and great teaching points, and get to reflect back. If you seek it, you'll find it. Kuchal and her team just kept going to find what was going on, and I think that was the most important thing for this patient, and that doesn't always happen. So kudos to you guys for looking and not stopping. But thank you so much. Everyone have a great day, great night, great morning. I know some people on here, they're awake at 3 a.m. So sleep well. And
a couple of, if you don't mind.
Oh, please do.
I just wanted to add a couple of teaching points which we when actually treating the patient. One was to earlier, prior to this, I've always seen only filariasis in legs, and then one case of hydrocele and one with a breast, which we thought which was inflammatory carcinoma and with a cutie orange appearance, but we did an FNAC and we saw microfilarial organism. But apparently for TPE, when we did the BAL, there was no microfilaria, and then there was just eosinophil cells. But apparently in the stage of TPE, you wouldn't have microfilaria in blood when we do the blood culture, because it's the hypersensitivity response, which is either type 1, 2, or 4, towards the microfilarial organism, which gets trapped in the lung. And that causes the eosinophils, like large amount, and then interleukin 4 and 5, which causes the IgE to be elevated and causes all the symptoms, which worsens in patients, especially with asthma, and they present with this symptom. And DEC, when you give only for TPE patients in stages of TPE, they kind of recover fully. But in case of when they already have filariasis, that is you can't cure them. You can just stop them from spreading it to another person, probably. So this guy was very lucky. This patient was very lucky that we caught it at a stage where we could actually treat him and cure him. But there's just no guarantee that you won't have a recurrence there. That was a great learning point which I had while treating this patient.
Wonderful. Thank you so much. And thanks everyone for coming, and we'll see you next time. Bye-bye.
Thank you so much, everyone. Bye.